So this afternoon, we're going to talk about prescribing medicines. We're going to talk about it in particularly with people who have trauma in their histories. And this is not just for prescribers. This will be important to hear because we're going to talk about a lot of things that we need to know about prescribing medicines. And the nurses, the social workers, the therapists are the eyes and ears that are very close to the patient. And you may see something that the medical doctors might not see yet. And you might say, hey doc, check this patient out, something is wrong. Okay, so we want you to communicate and we want us to all kind of understand these concepts. So first things first, we're going to start at the beginning. Does anyone know what this symbol is? Have you seen this for medical? Anyone know what it's called? Some call it caduceus. Some call it the rod of Asclepius. And what is on that rod? Snake. There's a snake. Why do we have a snake on that rod? Does anyone know the symbolism?
Це про дози отрути?
Wait, I can't.
Можливо,
Можливо, це про дозування, тобто, що отрута тоді отрута, якщо її забагато, але тоді лікувальна, коли достатньо.
That's exactly right. So the snake has poison. And what are medicines? Poisons. They can be. At the right dose, they can be very helpful. Just like snake venom actually can be very helpful in certain circumstances as an anti-venom for the snake bite. But it is often poison if it is not done correctly. But there's another reason. The snake also sheds its skin. And that is a symbol of healing and rebirth. And in medicine, we can take someone who is near dead, and in some miraculous way that science figures out eventually, we may restore them to health. So that is a good symbol. But we have to be careful. So, what medicine is best for my patient? I hear this question very often. People will come to me and say, Doctor, this is the situation. What is the best medicine? It depends. It depends on a lot of things. Two situations that may look very, very similar may actually need very different treatments. So we need to think about why things are different. So I want you to understand some concepts. Imagine I have a new patient coming to me for the first time, and I have 1 hour to hear their story, to listen to them, to ask questions, to find out what their goals are, and to come up with a treatment plan that involves medication. Maybe. That's not a lot of time, but we need to think about what happens in that hour. So I have to ask myself as they're talking, what kind of prescribing relationship does this patient want? This patient could come in very directive, everything written out, here is my plan, doctor, you must help me do this. Sometimes people will weigh different options, maybe this, maybe that, let me think for a while. And have you ever heard a patient say, I'm not the doctor, you tell me. So the amount of control over the situation, over the prescribing, is very different with different patients. Does that make sense? I also need to ask myself how frequently the patient would agree to take medications. Sometimes they are very strict daily. They will come in with a list of times and tell you every time they had that medicine. And some are pretty good, but they might forget once in a while. And some say, I really probably won't take it very much, but on bad days I would do it. And some patients say, I am not a pill person. I don't even take an aspirin or paracetamol. I don't want any medicines. So we need to think about what kind of adherence or agreement to the plan they would have, because that will make a difference if we are just prescribing every day, something where they could miss a dose and be okay, or maybe medications that need to be taken every day or they'll feel withdrawal or bad side effects. Okay, so there was the adherence. Some people are forgetful, or some people are very compliant. Some people not really a pill person. And I need to ask myself, what are the patient's past experiences with medications? They might never have had a medication before from a doctor. We call medication naive or totally unknown to me. Some patients might say, I've had medicines and they were helpful. I didn't have any big problems. It was okay. And some might say, I've had medicines and I didn't think they were really helpful. I had problems with it, or I had some side effects and I didn't really like it. And some people might say, I've had really big problems with medicines. I became suicidal when I had Zoloft or sertraline. They might say, I had a problem with my liver. I had to go to the hospital. Or that doctor gave me a medicine I became addicted to. It's terrible. They really hurt me. So this is going to affect how much trust the patient has in us. And we need to be sensitive to that, especially with trauma. Some of the traumas have been by the medical system on a patient as well. And this one is a little tricky. This one is more unconscious. So let's think like a good therapist here. Maybe the patient comes to me 2 or 3 times and they say, yes, I'd like to do this. And I give them the medicine. And the next time I see them, oh, I didn't start it yet. I was busy. I forgot. And the next time, oh yeah, I really want to do it, but I got busy. At some point I have to ask myself, is this more of a resistance? Is there something else going on? And a good question to ask is, do you think the patient deserves to be sick? And sometimes in trauma, especially with PTSD, patients can feel they deserve to be ill from what happened. And that if they got better, it would be forgetting everything they did, or it would be not honoring those who were left behind. So this can be especially tricky. So we need to measure resistance. And I also want to be very clear about what symptoms I'm targeting. I don't just want to give them medicine because they have PTSD. I want to find out if they're depressed, or if they're anxious, or if they can't sleep, or if they can't eat, or if they have nightmares. I want to know exactly what I'm targeting. I want to measure in the big picture, does the patient benefit more than the risks of the medicines? I want to think about the schedule, how often they'll take medicines. Daily, twice a day, 3 times a day. That gets hard for people. Only at bedtime, only once in a while. And I also want to be very conscious about safety. Is this someone who might abuse the medicines, might sell the medicines, might become addicted to the medicines, or might even try to kill themselves with the medicines? So we need to address suicidality. Doesn't mean you can't prescribe, you're just going to be careful, and maybe you won't give them as much medicine at one time, maybe a week at a time instead of a month at a time. And I also want to be concerned about any medical situations that are going on as well. The mind and the brain are still attached. So we can treat the mind, but we got to treat the brain and the body too. So we want to think about lab work, maybe an EKG, especially if we're doing antipsychotics, liver issues, especially if there's drinking as well, any neuro issues or TBI. Maybe they need to go to the sleep clinic for a sleep study. And what kind of follow-up do I want to do? Will I see them in 2 weeks, 3 weeks, 1 month? Okay? So the other thing I want to do is I have all of my thoughts about what I think should be good for the patient. But that doesn't matter so much if it isn't what the patient thinks is good for the patient. So they need to have some say in this. So I use a little technique called the magic wand technique. So once we are done with the main part of the consultation, and before we start talking about a treatment plan, I will say to them, now that we've talked about a lot of things and I understand your history a little bit more, I'm going to ask you a silly question, but just go with it. If I give you a magic wand and you could wave it and change 3 things about your mental health, what would you like to see different or better? Now I have to be very careful. I don't want to say, what 3 things would you like to change about your life? Because they will say, I would like to be rich, I would like to be handsome, and I would like to have a really, really good job. And I will say, I can't do that for you. I'm sorry. So we want to be realistic about mental health issues. Usually patients aren't going to say, I'd like to see my anxiety improve, or I would like to have less nightmares. They're going to say things like, I'd like a better relationship with my spouse. But if I'm irritable and angry all the time, that's really hard. They're going to say, I'd like to be a better parent to my children. Or I would like to show up to work every day on time and not be so sick. So they're going to give you some big operationalized ideas about how their life would be better if things were improved. And you have to kind of evaluate what that means. But usually it's something like, I'd like to feel like myself again. I'd like to get rid of this terrible feeling that I've carried around with me for a long time. I'd like to sleep better. So it's almost always, whatever they identify as the biggest priority is where I start, and sleep. So I don't want to forget about sleep. That's almost always difficult for patients with PTSD. So we need to consider both things, the highest priority and the sleep. So at this point, you make your differential diagnosis. What do I think this patient has? The patient may come in with a chart that says they're depressed, or they're anxious, or they're antisocial, or they're borderline. But maybe after a good evaluation, you realize really at the heart of it is trauma. It's PTSD. We need to think about that. Was the depression there first and they've been depressed a long time and then had a traumatic event and really have both? Or were they traumatized early and they have had mood changes, which have been depressed and feeling anxious, but it really falls under the umbrella of PTSD? So those are things we need to think about. And PTSD can look like a lot of other things, right? It can look like depression or anxiety, even psychosis with traumatic memories coming back, like almost like hallucinations. A lot of people come to me saying, I must have attention deficit disorder. I can't concentrate. I can't read a book. I can't focus at work. That's actually very common. Many people come to me for ADHD evaluations, attention deficit disorder evaluations. And a lot of times I have to think, is this cognitive issues because of depression, anxiety, trauma, TBI, or is it ADHD, or a combination? And things like bipolar disorder too. So I'm not going to go through all these symptoms, but you see that there's a lot of overlap with PTSD. So we're going to take what we figured out in this hour how much control they want over the medication, how much adherence they'll have with the plan, how much trust they can develop with you to be able to do this, and any things that are resistance, keeping you back. And then we're going to add to that what symptoms we're targeting: sleep, concerns about drug abuse. We want to always be careful of that, whether it's stimulant, alcohol, benzodiazepine, opiate, others. And we want to be aware of their medical concerns, because we certainly don't want to make anything worse. Isn't the motto, first do no harm? And once we have that, we can write a prescription. So that was probably the longest talk about how to write a prescription that you've ever heard. But those are the things you need to think about, and that's why it depends is a reasonable answer, because everyone is so different in all these other domains. So this is Viktor Frankl. He was a prisoner of war in Nazi Germany in a concentration camp, a Jewish gentleman. And he survived, unlike many others. And you'll see him every now and then. There'll be some more slides with him coming up. But he started a type of therapy called logotherapy. And I like this quote: "Those who have a why can live to bear with almost any how." So I know Ukraine has a pretty strong why they're here and why you're fighting. And this is a difficult how to live with. But I know you're very motivated and have a lot of purpose. But with medications, we just talked a lot about the how. And now we're going to talk a bit about the what. So recommended PTSD treatment guidelines. The first is psychotherapy. That is still the most effective intervention for PTSD. They're typically structured, they're evidence-based, and time limited, meaning it may be 16 weeks or so. Medications, particularly the selective serotonin reuptake inhibitors, or SSRIs, selective norepinephrine and serotonin reuptake inhibitors, or SNRI, Prazosin for nightmares. And there are other medications that are also used that may not have been studied directly for PTSD trials, but with similar mechanisms. There are other somatic treatments. We're not going to go into that today. And there's always the option of no treatment. Maybe this isn't the time for some reasons. Maybe it's not the time for medications. Maybe medications are okay, but it's not the time for psychotherapy. So we have to gauge that and what the patient's needs are in his life or her life. Medications, typically there's about a 30% remission rate in symptoms, which means they come down about 50% of what they were before. Placebo effect is also about that. But if someone is very ill, this may be enough to really help them get to the point where they're more functional in life. So this is still a good number. Means we could do better with medication development, probably. So let's talk a little bit about the selective serotonin and norepinephrine reuptake inhibitors. So just some basics about how to prescribe these. Typically, we start at a lower dose and build up over a few weeks. And this can help avoid side effects, typically gastrointestinal, diarrhea, nausea, anxiety or agitation, headaches. We want to increase the dose over 4 to 6 weeks. I typically do it faster in the hospital than I do outpatient because we're watching the patient very closely. And the evidence shows that patients with trauma symptoms typically require higher dosages, a little bit more than you would do for depression. You need to get to the higher end of the dose range. And you want to evaluate them for about 8 to 12 weeks, for 2 to 3 months, before you change the medication, switch it out to a different class, or augment it with a secondary medication. You want to continue for about 2 to 3 months and monitor them before you change the medication or maybe add a secondary medication. And notably, there's no specific pharmacologic agent, medication, that has been developed just for PTSD. We'll talk about that a little bit more tomorrow, but there's a lot of ways PTSD can present itself. About 608,000 ways if you actually do the math on all the different symptom sets that could be combined. Does that make sense? So just looking at what we call our first line medication. So if you were to start a medication, this is typically where you would start. And as far as the antidepressants, that's fluoxetine, paroxetine, sertraline, and venlafaxine. And I'm not going to go through every detail of the dosages here, but basically you start at a lower dose and build up to the maximum dose. All of these meds are typically given in the morning. Venlafaxine can also be used for anxiety. I find that it has a little bit harder withdrawal if they stop it or miss dosages. But we'll talk about that a little bit more. Let's talk about some of the risks of these medications. Suicidality is an important one. It's not extremely common in my experience. It's more common in people who are younger, teens and young adults. And sometimes I think it is because they are starting to feel better in some aspects of their depression, maybe in their energy and motivation, but not yet in the mood. So even though they feel very bad, they have the energy maybe to get up now and go actually harm themselves or kill themselves. So I think that is one of the things that is different about this. So we just need to be careful. It means that we see the patient more frequently at the beginning when we're starting medications, maybe in a week, 2 weeks maximum. And make sure they have contact for us, that we are following up well. Discontinuation syndrome for serotonin medications. If they are abruptly stopped, particularly paroxetine and venlafaxine, they can lead to stronger side effects of stopping the medicine. People can feel very sick. In venlafaxine, sometimes they call it brain shocks, where they feel like electricity in their brain. They find this very uncomfortable. And there's different things you can do. You can restart the medicine so that they're not withdrawing and then taper it down. But I think most importantly, you want to communicate with your patient. We are going to build up the medicine slowly, and if we stop it, we want to do the same coming back down. I think it's also really helpful to tell the patient, if you really don't like this medicine, please let me know, because I will work with you to stop it if that's what we decide. So they don't feel they have to hide that from you. Some of the more serious cautions syndrome of inappropriate secretion of antidiuretic hormone, and hyponatremia. This is a little bit unusual. We don't see it very often, but it can happen with these medicines. We want to check labs if we have concerns. Serotonin syndrome, which is like an overdose in serotonin. This is especially dangerous if we use a combination of serotonin medicines, and sometimes we do. Hypertension with venlafaxine and also bupropion. So we want to monitor the patient. We have the resource to send a blood pressure cuff home with the patient so they can check at home if I'm concerned. Or you can have them come in and have the nurse check them. Any questions on anything so far? We're going to go into more specifics of the medications here in a minute. So some of the other medications we can talk about. There are other antidepressants that are still commonly used. Duloxetine is one that's commonly used. In the US, it's also indicated for pain management, for nerve pain. So I frequently use this if people have mood issues, PTSD, and pain. Citalopram is another medicine. We use this cautiously in the elderly. We might have more EKG changes. Mirtazapine is another good one. This is a nighttime medicine, one of the few that's actually at nighttime. Also used often in the elderly and people with difficult with their appetite. They're losing weight or they're too thin. This will help increase appetite. Another class of medications that I often use are the anticonvulsants, particularly gabapentin. I like gabapentin because it has a broad dose range from 100 milligrams, usually 3 times a day, maybe 2, but typically 3 times a day, up to 1,200 milligrams 3 times a day. So we really have here a dose range from 100 to 3,600 milligrams. So we can really fine-tune this for patients. It was originally an anti-seizure medicine. But the really nice thing about gabapentin is not only can it help seizure issues, it's not the best seizure medicine, but it can help prevent that, especially if someone is drinking and may go into withdrawal seizures. But it also helps with kind of that irritability, that real sort of angry, I want to fight kind of feeling. I tell patients it might give you an extra second or two to cool down and think before you act. And they tell me it's true. It does help. Often I'll start 100 milligrams 3 times a day. And usually people need to get to 300 milligrams 3 times a day, or possibly 600 milligrams 3 times a day for PTSD. But I can fine tune that a little. If they feel it's sedating, I could give them 300 milligrams in the morning, 300 milligrams in the afternoon, and 600 at bedtime, or some variation of that. So it gives us a lot of flexibility. I find that it's very well tolerated. Most people don't need to stop it. Sometimes people find it sedating, and then I usually reduce the dose a little bit and see if it's still helpful. One of the nice things about this medicine is it can be as needed. So if someone stops it and starts it and stops it, they won't have withdrawal from it. They tolerate that very well. This is actually a medicine I use quite a bit. Another anticonvulsant is pregabalin or Lyrica. Typically, this is started by neurology more than psychiatry, where I practice. It's used more for the nerve pain, and I don't think it's studied to have as much effect on the irritability or anxiety components or withdrawal. But it is an option. Sometimes patients will come to you on this, especially if they come from medicine or neurology or surgery. Okay, questions on these? One second.
Чи є синдром відміни? Що буде, якщо людина самостійно перестане приймати ці ліки?
Які?
Пригабалін.
For pregabalin? I've not experienced it to have particularly strong withdrawal. People have stopped it outright. But typically with these kind of medicines, they might feel a little bit sick. But I haven't had extreme issues with it.
Yes, we have.
What have you noticed?
We have it because the patient has a very high dosage from previous hospitals.
Patients at very high dosages from previous hospitals had withdrawal.
Yeah. We are observing that the patients coming to us with other hospitals, and sometimes they have a dosage like 300, 400 milligrams per day, and they have a very bad withdrawal symptoms, and actually they are the high anxiety, range of emotions, and actually a lot of them actually seems like they're dependent on it. And that's why in our hospital we are flipping to haloperidol gradually from this.
And I think in our hospital we use 75 and 150. I don't see very high dosages like that.
Yeah, 75 is very, usually we are using pregabalin in acute situation. Yeah, it's much better and faster. But it's 75, 150, but not 400.
Okay, thank you. Any other questions?
Так, я би хотів поділитися досвідом. Я з прегаbalином маю досвід роботи з 2008 року. І чітко зауважив деякі речі. Так, прегаbalin викликає синдром відміни, він дуже схожий на опіоїдний синдром відміни. Роздратованість, розлади сну, болі у великих суглобах, поперек, колінні суглоби. Залежні від нього стають, але від певних форм у нас. Дуже часто використовується на фронті і поза фронтом у всіх госпіталях, якби прегаbalin є основним препаратом для купірування розладів сну, тривоги і больових синдромів. Дози у нас коливаються від 300 до 900. І те, що чітко, воно зазначено, що воно невідомий механізм дії, але прегаbalin, по суті, наступним поколінням після алфа-агоністів. Тому ми зазвичай, так як і Олег Романович сказав, що якщо є залежність від прегаbalin, ми переводимо на алфа-агоністів, а потім зміняємо. І ще, що в практиці зауважив, що є люди, діляться на дві категорії по відношенню до прегаbalin. Одна категорія людей відчуває від боління таке відчуття, як від алкоголю. Тобто є атаксія, мовна дисфункція, а інші люди, навпаки, вони більше розгальмовані, соціалізовані, більше спілкуються і говорять. І для мене це є показник того, що в першому випадку є залежність від алкоголю, а в другому випадку від опіоїдних препаратів.
From the way you describe that, it sounds very much to me like as we are suppressing CNS activity with the medication, and then that is suddenly lifted, we have this unbalanced GABA and glutamate. So you're getting like a hyperglutamatergic reaction with the increased activity and the agitation and maybe even sensation in their bodies. I'm not sure if you have that, but it sounds similar to that type of syndrome. Yeah. So I understand, you know, you have to do what you have to do on the front line to get people to the rear and treated, but it sounds like that's a tricky situation. Was there another question?
Мене цікавить питання стосовно, якщо пацієнт власноруч вживає надмірні дози цих препаратів, це може бути більше 1000 мг, це можуть бути препарати по типу синтетичного морфіну, і він займається цим власноруч і протистоїть лікуванню і одужує.
If the patient abusing actually pregabalin or the synthetic opioids, what to do, because this is kind of resistance to the treatment.
Sure. I mean, two issues, right? You have to monitor the physical, right? The medical side of things and make sure that they're not having physical reactions, that you could treat them either with supportive medications or perhaps, I think what you said, you switch them to gabapentin or something that would be like a medication substitution, like you would do with a benzodiazepine for alcohol withdrawal. You substitute the benzo for the alcohol and then slow the withdrawal down and let the body's physiology catch up with that over a week or two. So that would be my thoughts on that. I'm not sure how. My concern is that, like alcohol, the withdrawal might lead to seizures, which of course would be life-threatening. Unlike opiate withdrawal, which is just very uncomfortable. But benzodiazepine and alcohol withdrawal is deadly. And I'm more concerned that high doses like this would follow kind of the same pathway as alcohol and benzodiazepine. All right, thank you for the question.
No, it was fast. Just for a second. Ну, відповідь на це є складна, насправді.
На ваше запитання. І я думаю, частиною відповіді є не медичні, не лікарські засоби, а поведінкова терапія. Поведінкова терапія або обмеження, або авторитету, або багато є форм поведінкового лікування залежностей або зловживань. І тому, наприклад, у нас в лікарні у нас були випадки, коли так буває, що в одній палаті збираються декілька людей, які підсилюють один одного різними препаратами ззовні і не можуть цього контролювати. Ми мусили звернутися до військової поліції. Вони приїхали і виправили ситуацію. І все відділення заспокоїлося. Тому що військові, вони люблять дисципліну, а дисципліна – це того, кого є влада. Ми іноді таку річ робимо. Нам дуже важко з цим, але воно працює. Поведінкова терапія, я це називаю.
That's extreme behavioral therapy. Yes, of course, I think with anyone who has an addiction disorder, you would want to incorporate the behavioral therapy as well. There are CBTs for cognitive behavioral therapy for alcohol abuse, cognitive behavioral therapy for cocaine abuse, and other things like that. So you certainly would want to incorporate those treatments as well. I kind of missed saying that, but yes, that would be certainly appropriate. All right, let's talk about a couple other classes of medications that I use fairly frequently. So sometimes people have anxiety or insomnia, and I don't necessarily want to start with a medication that may cause too many side effects. I don't really want to start with a benzodiazepine or maybe more heavily sedating medications that have more side effects. So some of the ones I start with fairly quickly, especially if you don't know the patient very well or you don't know how they will adhere to the medication plan. Hydroxyzine, that's one you use, correct?
Yeah.
And diphenhydramine, which are both antihistamines. So they're allergy medicines typically. Hydroxyzine's data shows that it's a little bit better for treating anxiety than diphenhydramine is, but either one can be helpful. I typically use dosages around 25 milligrams. It depends on the patient. I might use 25 milligrams for anxiety during the day and 50 milligrams for sleep at night. Or if they're sensitive, I might use 12.5 during the day and 25 at night. But you have some flexibility there. They're safe. They're not controlled substances as far as addiction. They don't have addiction to it. And if they have allergies, they might feel better too. Some of the other medications, other antidepressants like bupropion, we'll talk about that for a minute. Bupropion comes in a couple different forms, short-acting and long-acting. I almost exclusively use the long-acting. It's a once-a-day medicine in the morning, with or without food, it doesn't matter. And it is an antidepressant, but in the US it is also a medication called Zyban, which is also for smoking cessation. So patients tend to feel less urges to smoke on this medicine, and it can be useful if they're wanting to quit smoking. There are a couple concerns with this medicine. It lowers the threshold with which one could have a seizure, meaning it can make a seizure easier to happen. Now, my understanding of this is it doesn't cause the seizure, but if someone has a reason to have a seizure otherwise, like they have a seizure disorder, or if they're drinking and going into withdrawal, it makes the seizure more likely to happen. So I want to be careful with this medicine and make sure I'm asking about their seizure history, either alcohol or benzo withdrawal related, or from epilepsy or any other kind of seizure disorder. It doesn't mean you can't use it. It just means you have to use your good clinical judgment and make a decision about it, if that's safe or not. I do prescribe this for people who are drinking. Sometimes they're drinking and they're not going to stop, but they are depressed and I need to treat it. But if they're not going into shakes and sweats and feeling like withdrawal, when they stop drinking for a day or two, then I might try it gently. I might start with lower dosages and just watch them closely. But I have found it to be helpful. The short-acting is twice a day. And the reason it moved to a long-acting once-a-day dose is because of insomnia with the nighttime dose. People feel a little bit more awake and alert on this medicine. So if you take it at nighttime, it can cause people to feel a little bit more restless or agitated or pace around the room because they can't sleep. So we just want to be careful for that. So I usually find the long-acting to work well. It has 3 dosages, 150, 300, and 450 milligrams. And I find most people do pretty well with 150 or 300. And occasionally I need to go to 450. Now, I can't tell you any science behind this, but I can tell you my clinical experience. With bupropion, I think sometimes the vets that I work with who have PTSD feel like it may make their PTSD symptoms worse. It's not everybody, it's a few people. But what they feel like is they feel they're more on edge or maybe more paranoid. They're looking around more, feeling restless and a little bit like scared. When I talk to patients, I say, sometimes people may have this response to this medicine, but if I put 100 people in a room, I won't be able to pick out who. We can only try it. Most people do well with it, but if you feel this, if you feel more paranoid or feel like you have fight or flight on this medicine, let me know right away and we'll stop it or reduce it. I have people who have experienced that at 450 milligrams, but did really well at 300 milligrams. Again, I think the important thing is talking to your patients ahead of time. It's called anticipatory guidance, or I might anticipate something in the future and I'm going to give you instructions now about what to do if this happens. So letting them know if they have these side effects, you're not going crazy. Let me know, I'll work with you. We'll get it right. Okay? Let's talk a little bit about nightmares. Prazosin is the medication listed in the guidelines for PTSD. Clonidine is another one I typically use. They both can work pretty well. Prazosin is a peripheral alpha-agonist. Clonidine is a central alpha-2 agonist. And I'm going to show you a picture on the next slide or in a couple slides. Both of these can lower blood pressure. Both of them are used for blood pressure also, originally. What we know about PTSD is that norepinephrine is increased in the CNS during sleep, higher than people who don't have PTSD. We also know that an increase in norepinephrine in the brain at night is related to nightmares. So turning this down and slowing down the release of norepinephrine or peripherally acting on that can help with nightmares. And people have less intensity nightmares, less frequent. Sometimes they go away altogether. Because they are both blood pressure medicines, we have to be careful for dropping their blood pressure too much. We don't want to make people fall down and pass out. So if someone is on the low end of blood pressure, like 118 over 62, I probably wouldn't start these. And clonidine, I think, would be the one that's a little bit more, would cause a little bit more drop. So I would be careful with that. A lot of our vets have high blood pressure. So bringing it down a little bit is a double benefit. The important thing is to, again, talk to your patients about what they could expect. When I start these medicines, I typically say, Why don't you start it on a day that you don't have much you have to do, like a Saturday or weekend or a day off of work? And I'd like you to start it at night and go to bed. You're going to be laying flat, so you're not standing up and likely to fall down and pass out. If you get up in the middle of the night to go to the bathroom, I want you to sit on the edge of the bed for a minute and just make sure you don't feel dizzy. And then when you get up, I want you to just make sure you're okay, and then go. It usually takes 2 or 3 days for the body to adjust to this, but in the first 2 or 3 days, they're more likely to feel lightheaded or dizzy. Sometimes patients tell me they have dry mouth with these as well. So we just have to, it's usually not enough to stop the medicine, but the big one is the blood pressure. Sometimes people feel very tired on these medicines, particularly clonidine. But I think that's because they've been running on such high adrenaline for so long that when we finally turn it down, they're recognizing how exhausted their bodies are. So I usually tell people to just bear with that for another few weeks and see if it gets better once you get more sleep. Because usually they're sleeping better. It's just like if you're drinking 10 cups of coffee and then you stop, you're like, oh, suddenly I'm asleep. But it's not because you're not drinking coffee. It's because your body was really, really exhausted anyway. And you were using something to supplement that to keep you going. Does that concept make sense? All right. Let's talk about the class of antipsychotics for a few minutes.
One more question for
Yes.
the clonidine and
Yep.
prazosin. For how long they should take it to start symptomatics go down?
How long should they take clonidine before they see symptoms go down? Really quickly, usually, within a day or two. So if it works, so this is the trick with clonidine. When it works really well, and you know it. If that is not the problem as to why they're having nightmares, then it's not going to work so great. But when you get it right, you know it. So I find it almost diagnostic. If the patient is having nightmares because of high norepinephrine, and they use clonidine and turn it down, they're better pretty quickly. They tell you they're going from 2 hours or 4 hours of sleep a night to now they're at 4 or 5 or 6 hours. And then you just work on the behavior too. You work on the sleep hygiene behavior. You work on whatever else might help with that, getting their circadian rhythm straightened out. We'll talk about that tomorrow. But yeah, you see it right away. When I talk to patients about nightmares and dreams, I usually try to quantify it. They might say, oh, I have nightmares pretty often. And I'll say, out of 7 nights of the week, how many nights do you have nightmares? And they might say, almost every night, but maybe there's 1 or 2 nights. So 5, 6. And I also want to ask them, when you wake up from that, are you able to go back to sleep? If it's so disturbing that you can't go back to sleep, that's pretty severe effect in your schedule. So if it goes from I'm having nightmares 5 nights a week that wake me up, I can't get back to sleep for an hour because I'm so upset, to I'm having nightmares maybe 2 or 3 times a week and they wake me up, but I go back to sleep in 5 minutes, that's a good treatment effect. That's enough for them to get good, decent rest. That might help mood and everything else. All right. We'll move on to antipsychotics. So there are many of them. I'm only listing a few. Because these are kind of examples of the others. So aripiprazole. That shouldn't say 2015. Aripiprazole should be 5 milligrams to 20 milligrams. Oh, I think that was the 2 to 15 milligrams. Well, I usually start at 5 or 7.5 and go up to 10 and then up to 20 if needed. So this one is used in the morning. It's a little bit more activating. People feel a little bit more awake and alert. So you don't want to give it at night. There's also a warning for the elderly because it can cause EKG changes. There was some concern for Toussaint de Pointes or EKG changes leading to ventricular fibrillation. So we want to be cautious with that. There are probably other choices you can use. I find it to be a pretty good medicine. It's also approved as an adjunct medicine to go along with the antidepressant. So if you're giving an SSRI or an SNRI and you have partial effect but not enough effect on depression or your other target symptoms, it may be reasonable to add a little bit of aripiprazole because they kind of work together to give a bigger effect. They kind of make the antidepressant work better. Quetiapine or Seroquel. One of the things that differentiates this medicine is it's more sedating. So it's often used to help someone sleep as well if they're feeling agitated or if there's any psychosis. Help them get a good night's sleep. Weight gain is a risk on this medicine. It has multiple forms, short-acting, longer-acting. It has orally disintegrating forms that you can get in and they dissolve in their mouth. Olanzapine, 5 to 20 milligrams, up to 30. I typically don't use that high dose, but I'm not usually seeing the most acute patients in the hospital. This one is considered weight neutral, meaning people shouldn't gain weight on it. Also comes in the orally disintegrating forms and long-acting injectable. Lorazepam or Latuda, 20 to 120 milligrams a day. The trick with this one needs food in order to be absorbed into the system. So the way this one is given is with the biggest meal of the day, usually dinner. So people typically take this in the evening. Questions on these? There are lots of other antipsychotic choices, but you just have to kind of weigh that out and speak with your supervisors too about their favorite medicines. Yes.
For how long you
recommend to take this antipsychotic medicine to patient with nightmares?
I mean, I wouldn't typically be prescribing it for nightmares, but I might be prescribing it for sleep, to help them with sleep if they are agitated, if they're having real difficulty. With antipsychotics, some people are on it long term because they have psychosis or psychotic disorder. But with PTSD, I find that I can usually switch them off of it fairly soon. So, I mean, you're seeing very severe cases. If I were seeing someone in the emergency room or inpatient, I think this is a pretty reasonable emergency room medicine and acute inpatient medicine. But I do want to move them off of it because of the metabolic side effects as soon as reasonable. Some people like how the Seroquel feels because it really knocks them out. We'll talk about this tomorrow, but it doesn't give natural sleep. We'll talk about sleep architecture or the way sleep is built. A lot of the very sedating medicines don't allow us to dream like we should. They don't allow us to go into the deep delta sleep. We'll talk about that later. So what we want to do when we get our patients sleeping is we want to have the most natural sleep as possible. Benzodiazepines, antipsychotics don't really give us the most natural sleep, but they can get someone to sleep if they really need to get there. Okay? So I typically use it when I need to and for as short a length of time as I can. So this is just a little diagram. We got the brain here, eyes are here, back of the head is over here. And I'm sorry I didn't translate all of this, it was just very busy. But we have this spot here in the middle called the locus coeruleus. I promise you there won't be a test. But the locus coeruleus is the place where norepinephrine is released throughout the brain. So it's made here and distributed in nerve fibers all over the brain. So when we go into fight or flight, we squirt adrenaline all throughout our brain, which does a whole lot of things. But we also know in PTSD, if you look over here, this was a movie stimulus of something that people found to be scary. And people with PTSD are the black dots. People without PTSD are the white dots. And you can see that norepinephrine shoots way up more than normal for people that have PTSD and takes a while to come back down. This is in the cerebral spinal fluid, measuring it. This is just showing the relative differences at each time point. But really, this is the picture to look at. These are kind of folks that don't have PTSD. You still get an increase, but it's shorter and not as high. So norepinephrine is primed by trauma. So when we have traumatic experiences, our brains remember that in some way, some biochemical way. To say, when I see that tiger jump out at me the second time, my brain already knows to be ready and go. So we get that extra boost and extra duration if we have the context of past trauma. So, hang on. I think of it as the adrenaline faucet. So this is how I describe it with patients. I say it's kind of like this faucet in your brain that turns on adrenaline. And when we get scared, the adrenaline comes on, and then we get to the end of what we're being scared about, and we're better, and then it turns off. That's how it should work. But your faucet is working extra. So it actually stays on halfway all the time. And then if something jumps out, it goes way up, stays on longer, and it's really hard to come back down. And it doesn't come back all the way down to how you were before. It comes back halfway down and keeps you half ready. When I explain this to patients, they kind of understand that. They can get that. If I put up the brain figure and show them all the neuron connections. But telling them about the adrenaline faucet is a really handy thing. I've used it a lot. Seems to be something people really understand well. So in this figure, this is a presynaptic neuron terminal. This is a postsynaptic, the one that has the receptors on it. These are vesicles that are connecting here and releasing neurotransmitter. So in this case, clonidine medicine acts on this receptor on the first neuron. It is called the alpha-2 noradrenergic or norepinephrine receptor. What happens when you activate it, it gives negative feedback. It goes, hey, stop releasing. It's like stepping on the brake. And these don't release as much. So this is the way we turn down the release of adrenaline or epinephrine. This is just a fairly straightforward diagram. People that don't have PTSD, people that do have PTSD, they just have more norepinephrine going on all the time. Okay? That's kind of all I wanted to say about that one. Okay. Everybody still awake? All right. So let's talk about some sleep medicines. And in particular, I'm going to talk about non-benzodiazepine sleep medicines. Benzodiazepines really shouldn't be used for sleep. That's not what it's indicated for. They're often used for sleep and often abused for sleep. But let's talk about some other choices. One of the medicines that we use in the US is melatonin. It's something natural that occurs in our brains anyway. I've heard from colleagues here that the melatonin may not be the same as what we have in the US exactly. But in my experience, and let me just tell you a little bit about the brain. We have a place in the brain that squirts out melatonin naturally. And what should happen, especially before we developed computers and lights and electricity, what should happen is when the sun starts to go down and it gets to be dusk, evening, our brains squirt out melatonin. That goes to a place in the brain called the thalamus, makes some proteins, and those proteins then help with the onset of sleep. This is where we feel tired. Like, I could go lay down now, I'm getting a little sleepy. That takes about 2 hours. So the trick with melatonin, to have it act like our normal melatonin, we would give it 2 hours before bedtime. Often people take it right before bedtime and say it doesn't work. Or they'll take it right before bedtime and say it didn't last long enough or are too sleepy in the morning. So we want to try to mimic natural sleep as much as possible. And because this is naturally occurring in our bodies anyway, it helps give us the most normal sleep architecture as possible. I like to think of it as a circadian rhythm stabilizer, more than a sleep medicine. It's used best when it's taken the same time of the day every day, and you get into a very good sleep pattern. So I find that the most helpful. We talked about hydroxyzine already. Trazodone is another medicine, trazodone is another medicine. It's actually an SSRI, but it doesn't work very well as an antidepressant because it makes you too sleepy at dosages that will help with depression. Because of this, they thought, hey, let's use this as a sleep medicine. One of the concerns with trazodone, some people don't tolerate it very well. A lot of people think it's okay. I usually start 25 milligrams, go up to 50, 100, 150, maybe 200. There is a concern for priapism, which is an erection that doesn't go away in men. And this actually can be a medical emergency. So it's really important to tell your patients, especially your men, I think only your men, but it's really important to tell them that if they have an erection that doesn't seem to go away, it could actually be a side effect to the medicine. Because that is not the first thing they're going to think of. They're going to think something else happened. But they do need to stop the medicine if that happens, supportive therapy, and I've actually seen cases that had to be surgical. Okay, there's a question in the back.
Якщо переводати, якщо мене почуєте звідси, не чуєте, але рахунок приапізму. Чи є якийсь дозозалежний ефект? Тобто на яких дозах найвірогідніше може виникнути ця патологія? Чи воно не залежить від дози? Дякую.
So the priapism effect in trazodone is that dose response related. I think when it happens, it's so rare of an occurrence that I don't think we have exceptionally good data on it. But if it can happen in your first dose, and it can happen later on when you go up to a higher dose. It can be quite variable in different people, but once it happens, they shouldn't have that medicine ever again. Okay, it is still an extremely rare occurrence. I think I've seen it 3 times in my career. So some of the other sleep medicines, particularly ones that like to be prescribed by our sleep clinic doctors, Azopiclone, which is Lunesta, Zaloplan, which is Sonata, and Zolpidem, which is Ambien. Ambien has long-acting forms as well. They all work sort of on the GABA pathway, but a little bit different, the inhibitory pathways of the brain, but at a different site than the benzodiazepines do. Sonata is a pretty short half-life, which means it helps getting to sleep, if that's the person's problem. Let me back up and say, when you are assessing sleep, you want to ask a couple questions. You want to ask, are you having trouble falling asleep? Are you having trouble staying asleep? Are you getting up too early in the morning? So there's different ways sleep problems can show themselves. So if someone is having trouble getting to sleep, maybe Zaloplan or Sonata is more effective. But if they want to stay asleep through the night, you want something longer acting, like Lunesta or Azopiclone. Zolpidem is a pretty commonly used one, Ambien. And at the hospital I work, that's the more easily available one, typically. So you have a bit more dose range and formulation choices with it as well. The problem with some of these medicines is they can actually cause some parasomnia, which could be sleepwalking, sleep talking, sleep eating and cooking, and sleep driving. So these can be quite dangerous, actually. So we want to be very cautious with our patients. They are best used if they have someone in the home with them that can kind of watch out for them. People can really feel like they're acting out their behaviors while still asleep. Normal sleep, the part of our brain that does behaviors gets shut down, right? We turn that off, otherwise we would act out our dreams all the time. So we have a disconnect switch in our brains. This bypasses it a little bit. So we want to watch out for those kind of things. They can be quite effective medicines. Okay. So let's talk a little bit about benzodiazepines. When we think of PTSD, the general concept is we avoid benzos. They're not a good medicine for PTSD. These are medicines like Ativan, lorazepam, diazepam, alprazolam, temazepam. Part of the reason, and if you think of Dr. Harpers-Rodham's talk earlier, part of the reason is that they're really not good for PTSD is they're like a pharmacologic avoidance system. It's like if you take the medicine, you are a little bit numb, a little bit like insensitive to things. And the treatments in PTSD actually require you to think about things that may be a little bit disturbing, right? Things from your past or such. If they were on benzodiazepines, you can't really get there to get them through the therapy. I try not to start these if I can help it. Often patients come to me already prescribed a benzodiazepine. So if that's the situation, then what I want to do is try to move them to a longer acting benzodiazepine, go from something short acting like Xanax, which I think is a really bad medicine, to a longer acting form like Ativan or clonazepam, something that would be a 12-hour half-life. The faster on and off a medicine works, like Xanax. You take it, you feel it right away, and it leaves your system pretty quickly in a couple hours. That increases addiction potential. So think about that with meds. The faster on and off they switch, the more likely it is to switch into a craving system. So I want to switch them to longer acting. Maybe I'll start with Ativan with a 4-hour half-life and move to clonazepam. And then maybe I'll move them off of a benzo onto a different type of sleep aid. Okay, because ultimately I'd probably like them to be off of the benzodiazepine, especially if they're older. Benzodiazepines can increase cognitive issues, falls, confusion in the elderly. A lot of falls and hip fractures in the elderly are related to benzodiazepine use. But one of the things about these medicines is they're pretty effective for anxiety. You feel it right away. Some of our other medicines take a little bit longer to feel, especially the SSRIs, which might take 2 or 3 weeks. These fast on-off medicines also can give a rebound anxiety. So you take the medicine, you feel better, and then it gets out of your system and you feel worse, but you feel even more worse than you started. Most people will then say, oh my gosh, my anxiety is even worse. I better take some more. And then they take more and more and more. And that's how we escalate in addiction. So we want to interfere with that cycle as best we can and keep people from getting there in the first place. Now, saying all that in the context of PTSD, I want to say there's still effective medicines for alcohol and benzodiazepine withdrawal. So they still are your first choice medicines if someone is in alcohol withdrawal. If you think about alcohol withdrawal in the brain or benzodiazepine, we're going to think of them together. The brain is chronically suppressed by increasing GABA, the inhibitory system of the brain. So it's like we're applying the brake all the time. So if they abruptly stop it, all of a sudden you have too much glutamate, because glutamate and GABA have to balance. If you've always been adding more GABA, inhibitory, the glutamate had to increase too to balance it. So as soon as you take out the benzo, all of a sudden there's way too much glutamate relative to the GABA. And with too much glutamate, you get a hyperexcitatory state in the brain. So that can lead to feeling nerves in your arms, shocks, electric shocks, pins and needles, feeling restless. It can lead to hallucinations, particularly visual hallucinations. It can lead to seizures and death. Okay? So with benzodiazepine or alcohol withdrawal syndromes, we do want to treat them effectively. And we substitute what they're using with a clinical benzo and then bring that slowly down so the system can stay in balance until they taper off. Okay? Now you might have somebody with PTSD and alcohol withdrawal. You're going to treat the severe thing, the alcohol withdrawal. And then we're going to work on the rest of the story. Okay? Does that make sense?
Yeah.
Okay. So there's a term that I like to use called intelligent deprescribing. So this means we're going to be really careful and think through how we're going to reduce medications. I often tell people that half of what I do is stopping medicines. Because they call me a prescriber. You prescribe medicines all day long. And I said, well, I discontinue them all the day long too. So deprescribing is the process of tapering, stopping, discontinuing medications with the goal of managing polypharmacy and improving outcomes. So when patients are on many medicines, we have to worry about interactions between medicines. We have to worry about synergistic effects that may worsen cognition. We have to worry about effects on the liver and the kidneys. So when someone comes in and they have 15 medications, one of the things I always say is, let's see what's really needed and let's see what we can maybe reduce or get rid of. Maybe you have 2 medicines when we only need 1 for something. People come to the hospital and they leave and medicines are started and then they sometimes don't follow up and nobody stops the medicines and another doctor comes along and starts more. So we want to be very careful with this. I call this medication optimization. I want every medicine that you're on to be something that's meaningful and useful to you and not hurting you. So sometimes people are afraid to deprescribe medicines. Maybe they don't really know how to do it well. What can you stop all of a sudden and what do you have to taper? Lack of training in this. Maybe beliefs about the medicine in some way or beliefs about your own skills in some way. But it is important to look at medicines thoroughly, look at the whole list, discuss it with medical providers if needed, and then come up with a plan to reduce medicines where you can. Okay? Does that make sense? Have you seen patients that have these huge med lists that don't make any sense to you? Yeah. All right. So, in summary, a personalized medication plan has many aspects, including the patient's view of control, adherence, trust, unconscious resistance, safety, and medical concerns. So there's a lot to think about before you start to write a prescription. It's important to follow treatment guidelines. However, each patient is an individual, and you must make individualized decisions using your best clinical judgment and advice of supervisors, being respectful of the patient's choices, environments, and needs. So no 2 people usually have the exact same medication plan. They don't have the exact same livers to metabolize medicines. They don't have the exact same kidneys and genetics. So we need to take an approach that really weighs these factors. Benzodiazepines are generally contraindicated in PTSD because of the pharmacologic avoidance. I can just make myself numb and get through the world. And that doesn't help them. It actually keeps the PTSD going. And deprescribing is just as important as prescribing. Titania? Thank you.
там одна дівчина, а потім ви.
Я хотіла вас запитати на рахунок капріона, і чи було на вашому досвіді те, що на невеличких дозах, оскільки він є активуючий, у ветеранах він викликав суїцидальні випадки, можливо, навіть тенденції? Дякую.
I think that's something you always have to be conscious to watch for. I don't think that bupropion is any more likely to do it than any of the other medications. I think the factor I'd be more concerned about is, are they younger, adolescents or young adults? I'm going to be much more cautious. Or if it's somebody who this is the first time they've been on an antidepressant, I'll be very closely watching that as well. I use bupropion a lot, actually. A lot of my vets want to quit smoking too, and we use both effects. Some of the vets don't like the sexual side effects of SSRIs. It tends to lead to difficulty with an erection, arousal, or ejaculation, sort of the three components of male sex. And in women too, they can feel less arousal and ability to have an orgasm. And if we're working with a lot of young men, they don't want to feel that way. So bupropion is one of the medicines that doesn't have that side effect. As a matter of fact, sometimes I use it in combination with an SSRI to get rid of the erectile dysfunction side effect. Use the two meds together, they get a good effect from their SSRI, and the bupropion helps get rid of the inability to have sex. But as far as suicidality, I don't think it's specific to bupropion, even though it's activating. I think all of them run that risk. If you are more activated than you are undepressed, you unbalance that and run more of the risk of being able to complete an act of suicide. But I don't think it's specific to bupropion. And I think it's also very rare. So a good suicide assessment and a good decision about how often you're following up with people that are higher risk is key, more than which medicine it is.
Олег?
Мене цікавить, ви розказуєте про норадреналову систему. У нас пацієнти з ПТСР почали з'являтися з 2014 року, з початку першої війни. Речі, які я зауважив, вони для мене якось чимось були нагадували пацієнтів адиктивних. І в 2019 році виходить маловідома стаття італійського з Італії, Principles of Prescribing, якщо не помиляюсь, про роль дофамінової системи як ключової у формуванні ПТСР. І серед тих всіх препаратів, які ми бачимо, наприклад, аріпіпразол, це є, який впливає на D3, рецептори. Тобто ми використовуємо препарати, які порушена дисрегуляція дофамінових рецепторів через надмірну гіперактивацію медалу. Тому і виникає страх людини. Але знижений рівень дофаміну, він, власне, тому і виникає зменшення мотивації, ангелінію і апатії. І я подивився, наш ворог використовує, і китайці використовують для лікування ПТСР препарати, які активують дофамінову систему. Це такі, як метилфенідат, атомоксетин, навіть кетамін, він має вплив на зворотнє захоплення дофаміну. Тобто він залишає дофамін в синаптичній щілині. Не тільки на НМДА, але й на дофамін. Власне, ваше відношення до такої теорії.
I wish we were able to be incredibly specific about how the system is being modulated. The fact that always gets me is that each neuron connects to about 40,000 others. So we are pushing a system in a direction with medications that typically hit more than one receptor. So even though there are dopamine specific medications or serotonin specific medications, they do hit the other receptors as well. And the trick with receptors is you have to get them like enough binding to that system that you overcome the barrier and allow the signal to pass. Some of those are at 40% occupancy of the receptor. Some are at 80% occupancy of the receptor. Some of them are inverse agonists. Sometimes we want the balance of dopamine and serotonin to be a certain way, or serotonin and norepinephrine, or norepinephrine and dopamine. So this is always confounding to me as well. And it really takes, I think I step back and I look at the flavor of the PTSD. So is someone coming to me with a very agitated, fight or flighty, sleepless PTSD, which may be like a newer PTSD? Or is someone coming to me with a very depressed PTSD, hard to get out of bed? Or is someone coming to me with a very anxious PTSD? Each of those, I think in my thinking, I kind of divide them into those camps. And I try to use the medications that sort of counterbalance what's happening. So if it's very activated with norepinephrine, granted dopamine is suppressed, right? So we're not getting as much, if you think about it. In combat, it's going to be very exciting. And dopamine is going to be up there really high. And you get this baseline elevated dopamine, so the whole system accommodates to that. So relatively, you're not going to have as much dopamine. So you have a relative deficiency. So then when they come out, they feel numb. They want to do risky behaviors because it's the only way they can feel good. Matter of fact, I was working in a cognitive behavioral therapy for addiction. And one man stood up and he said, you know, when I came back from Afghanistan, where I was a machine gunner, I could never feel good again. I could never feel normal again unless I used cocaine, which of course is dopamine, right? VTA, dopamine. He said the only way I could feel anything was with cocaine because the system's been affected and altered so much by these kind of things, these traumas. So I'm kind of looking at the way the PTSD presents and trying to meet it and match it. And it's a dance, right? And if that doesn't work, I'm going to shift. I tell the patients, if this doesn't work, we're going to adjust fire. Nothing is fixed. And we just have to get to that combination that's right for that individual. And it takes a little trial and error sometimes. But yeah, you've got to be thinking about all these things and trying to be intelligent about how you're approaching it.
Дякую, Олеже. Це така тема серйозна. І ми закінчуємо на ній для того, щоб продовжити пізніше. Декілька таких підсумовуючих моментів. По-перше, в нашій лікарні, і я раджу це вашим лікарням, ми заборонили використовувати бензодіазепіни для військових. Жорстка, якщо психіатр призначає, він має пояснити, чому він це робить. Це можливо, це лікарський засіб. Дуже шкідливі ліки. Так само, як практично заборонений прегабелін в цій лікарні. Друга є дуже важлива річ – це SSRI, які дуже часто приписуються направо і наліво. Але треба пам'ятати для військових про важливі побічні дії, в тому числі і порушення еректильної функції, яке впливає неймовірно на молодих хлопців. І третя річ, чому ніхто з вас, я не знаю, чи ми це не запитував, але справді використання певних препаратів для лікування нічних кошмарів є дуже ефективне. І хто знає іншу назву, крім психіатрів, іншу назву препарату Clonidine? Клофелін. Який облік клофеліну в лікарні?
Список червоний рецепт.
Червоний
Зараз
рецепт,
електронний.
червоний рецепт, так.
Ні, на клофелін таблетований, форма.
І ми можемо купити його. А чому ж тоді в лікарні він такий під
Я
таким?
виписую, тому що я призначаю
Microphone.
презентування
There's a microphone behind you.
і опіоїдні абстиненти. Так,
Клофелін у нас можна купити, він єдине, що доза за кордоном є 1,1 мікрограм, а у нас
Ну, бачите,
150 або 75
Та
мікрограм.
наша лікарня відстала, тому що в нашій лікарні є жорсткий облік, де ми в принципі не можемо цим користуватися.
То ампульований.
Так, так. Окей? Так?
У нас теж список А, і приходить наркоконтроль, в тому числі його теж перевіряє разом з опіатними.
Бачите, думки фахівців первинної ланки і вторинної ланки розійшлися.
Ну, можливо, в тому, але в нас облік далі лишився.
Ну, тобто в поліклініках облік на кафедрах, ми знаємо, хто буде сидіти. Окей, і це дуже важливо, тому що це препарат хороший для використання, але є ще одне питання: це нагляду і догляду за пацієнтом у стаціонарних умовах. Це є контроль тиску перед призначенням і під час призначення. Але препарат дуже якісний, і ми повинні ним користуватися і не повинні боятися цього. А ми справді боїмося. Чому були декілька випадків, коли пацієнти були неконтрольовані і мали стани, які загрожували їм життю і здоров'ю. Дякую дуже.